In the early 1950s, a psychoactive compound was legally administered in hospitals across North America and Europe. It appeared in psychiatric journals. It was discussed at medical conferences. It was described as precise, controllable, and temporary. What later defined this period was not the compound itself. It was that many patients did not know what they had been given, or how much. Some only learned decades later. Why this was acceptable? Post-war psychiatry was under strain. Hospitals were overcrowded. Patients were institutionalized for years at a time. Available treatments were invasive and often irreversible. Standard practices included electroconvulsive therapy, insulin coma therapy, and psychosurgery. Against this backdrop, LSD appeared modern. Early researchers believed it could temporarily alter perception without causing physical harm. They believed it allowed clinicians to observe the mind in real time. They believed it could accelerate psychological insight. Published articles described LSD as predictable within dosage parameters. What those articles rarely discussed was how those parameters were chosen or explained to patients. What patients were told? Most subjects were already hospitalized. Many were told they were receiving a medication to help with mood or clarity. Others were told nothing beyond that it was part of treatment. In many cases, the name of the drug was not disclosed. Consent, as it is understood today, did not exist. Participation was assumed to be part of care. Dosing information was not shared. What the records show? Clinical records from the era consistently describe similar effects: altered perception of time, disruption of personal identity, heightened emotional response. Published studies from the 1950s and early 1960s report LSD doses ranging between 25 and 250 micrograms, depending on the protocol. Some patients received a single dose. Others received repeated administrations over days or weeks. These reactions were considered expected. In rare cases, patients later described the experience themselves. Patient Account 1, Psychiatric Inpatient. The first documented account comes from a patient hospitalized in the late 1950s for depression. They were told they would receive a treatment intended to promote emotional insight. No drug name was provided. Years later, through medical records, the patient learned they had been administered approximately 100 micrograms of LSD, a dose considered moderate to high by modern research standards. The onset was subtle. The patient noticed heightened awareness. Light reflections appeared sharper, background sounds more distinct. Within about an hour, the experience intensified. They described losing the ability to guide their own thoughts. Ideas appeared fully formed without intention. They later said, "My thoughts didn't feel like mine anymore. They arrived already finished." As the effects escalated, the patient experienced a breakdown in identity. They knew factual information, name, age, location, but no longer felt connected to it. They described it as knowing who they were without feeling like that person. Time perception became unstable. Minutes stretched unpredictably, then collapsed. The patient attempted to anchor themselves by recalling personal memories. Those memories felt distant and emotionally neutral. At one point, the patient asked hospital staff whether the experience would end. They were told it was temporary and should be allowed to continue. No explanation of substance or dosage was given. The patient later described interpreting this lack of explanation as confirmation that something irreversible had happened. Fear set in, not of dying, but of never returning to a stable sense of self. Clinical notes from the session described the patient as emotionally reactive and resistant. The patient's own account emphasized internal disorganization rather than emotional distress. They described several hours of sustained cognitive fragmentation, consistent with LSD's known duration at that dose. After the effects subsided, the patient was returned to their ward. There was no debriefing. In the following days, they reported persistent anxiety, difficulty trusting their thoughts, and fear that their identity had been permanently altered. These symptoms were recorded as part of their underlying illness. Only years later did the patient learn what they had been given, how distress was interpreted. At the time, Destabilization was often viewed as therapeutic engagement. Emotional intensity was seen as progress. If patients worsened afterward, it was attributed to their diagnosis, not the intervention. This framework went largely unchallenged, until patients began speaking outside the system. Allen Memorial Institute. The second set of accounts comes from patients treated at the Allen Memorial Institute in Montreal under psychiatrist Ewan Cameron. Many were hospitalized for anxiety, depression, or stress-related conditions. Former patients later obtained records indicating they had been administered repeated doses of LSD, often between 50 and 150 micrograms per session. Some sessions occurred daily or near daily over extended periods. Patients were not informed of the substance or dosage. One former patient described entering sessions without any understanding of what would occur. Over time, they lost track of how long they had been hospitalized. They described difficulty recalling personal history and daily routines. Thoughts appeared disconnected from context. They later said, "It felt as though my personality had been taken apart piece by piece, but nothing was put back." The patient attempted to recall familiar information, names, preferences, past experiences, and found them inaccessible or emotionally flat. They reported difficulty forming new memories between sessions. Medical notes described this state as regression. From the patient's perspective, it felt like erosion. After discharge, the patient struggled to return to work. They described persistent confusion about identity and reduced confidence in decision-making. At the time, these effects were not attributed to experimental procedures. They were considered part of the illness. The conditions around the drug. In several studies, LSD administration was combined with controlled environments. Patients were placed in reduced sensory settings with minimal social interaction. The goal was to amplify internal psychological processes. Patients later described difficulty reintegrating sensory input after sessions. These effects were documented, but not ethically questioned. The turning point. The change did not come from a single discovery. It came from convergence. Former patients began speaking publicly after discharge. Some accessed their medical records for the first time. They learned what substance they had received, how often, and at what approximate doses. Their accounts contradicted the belief that effects were temporary. In Canada, former patients from the Allen Memorial Institute filed complaints and lawsuits. Their testimony brought these experiences into public view. At the same time, medicine began facing external scrutiny. In 1964, the World Medical Association revised the Declaration of Helsinki. For the first time, it established explicit standards for human experimentation. Subjects had to be informed. Consent had to be voluntary. Vulnerable populations required special protection. This gave institutions a framework to question existing practices. Then came exposure. In the early 1970s, US congressional investigations revealed details of MKUltra and related programs. While distinct from hospital-based studies, the revelations had a profound effect. The public learned that psychoactive substances had been administered without consent and with minimal oversight. Tolerance collapsed. What had once been framed as ambitious science was now seen as institutional failure. How practice changed. Medicine responded structurally. Hospitals and universities adopted institutional review boards. Formal informed consent became mandatory. Independent ethics oversight became standard. Drug names had to be disclosed. Doses had to be explained. Patients gained the right to refuse. Research did not stop, but it slowed and became accountable. Why this matters? Modern psychedelic research exists because of these reforms. Today's protocols require screening, preparation, consent, and post-session integration. The compound is not fundamentally different from what it was in the 1950s. The system is. This chapter of medical history is not remembered for a discovery. It is remembered for a realization that treatment without consent is not treatment. It is exposure.